Okay, I would like to now introduce one of our MPHP medical directors, Dr. Arthur Hildreth, who's been working with MPHP for several years now. He's a psychiatrist and a wonderful resource for our program, and he will be introducing our presenter tonight. So take it away, Art.
Okay, as Margaret has said, I'm medical director for the uh, Maryland Ph.D. program, and we're very pleased to have Dr. Jill Starr talk about addressing a stigma that's associated with mental health and substance use disorders within the healthcare profession and community. This is an extremely important subject and an important factor that because it influences decisions to talk to colleagues about entering into the whatever their local physician's health program is, and to making decisions themselves should they think it's going to be helpful to participate. Dr. Starr is a licensed clinical psychologist, having gotten her degree from Central Michigan University. She is, at the present time, has had experience in the assessment of professionals. She is now provides personality assessment for psychological treatment for dual diagnosis at the University of Florida Health Recovery Center. She's qualified to teach cognitive behavioral therapy, particularly as it relates to anxiety disorders, depression. She supervises this type of treatment, and we're very pleased to have her give a talk to us tonight about this really important subject. So take it away, Jill.
All right. Well, I appreciate being invited to this and getting to be here tonight. I was first made aware of a Zoom session because I was attempting to connect via telehealth to one of my patients this afternoon, and we use Zoom as part of our telehealth services here at the University of Florida, and wasn't working. And so I'm very thankful that we found a different resource, myself and my patient, and that Zoom is now back up and running. So I definitely have my fingers crossed that this will go pretty well. But this is also a subject that's extremely near and dear to my heart, just because of the work that I do. I have worked with several patients over my years, and I'll have a slide where I talk a little bit about who I am and my background as well. And stigma is something that comes up quite frequently in my work with patients. So concerns about what their colleagues are going to think about them when they go back, what their medical directors think, what the medical boards think. And so I am here, as was already stated, to talk about addressing the stigma associated with mental health conditions, as well as substance use disorders within the healthcare professions and just the greater community. So as I mentioned, I am going to also give a little introduction of who I am. So yes, I received my PhD in clinical psychology more years ago, back that I'd like to admit, from Central Michigan University in the good old center of the Palm, up in Michigan. I then matched at the University of Florida for my pre-doctoral internship through the clinical and health psychology program here at the University of Florida. So I moved my way down to Gainesville in 2010. And then, as I usually tell my patients, I've been here ever since. It was in 2013 that I joined on the staff full-time at the University of Florida, UFHealth, Florida Recovery Center. And now my role is as a clinical psychologist here at the FRC. And as was already mentioned, my primary role here working with our patients is to provide individual psychotherapy, primarily to the patients who have some of these dual diagnoses. So anxiety, depression, PTSD, other trauma-related histories. I run cognitive behavior therapy groups, which I'll tell you more about near the end of today's lecture. And I run personality assessments using the MMPI-2. That is primarily with the non-healthcare professionals, only because we also have 2 neuropsychologists full-time on staff whose primary role is to provide an extensive neurocog evaluation of physicians who come to us for treatment. I am a course instructor, so here at the University of Florida, we have an addiction counseling graduate certificate that's offered really to anybody who wants to sign up. I've had physicians sign up for it. I've had social workers sign up for it. I've had students sign up for it, and even around the globe. So 2 years ago, I had someone from Japan join it. But basically, it's 6 courses that you complete, and then it allows you to say, I've completed an addiction counseling graduate certificate. I have participated in 4 of these 6 courses as an instructor. I'm not going to read through all of them. You can see there, but a lot of it focuses on treatment at all stages of treatment for individuals seeking treatment for any kind of substance use disorder. And then finally, here at the University of Florida, we have an interdisciplinary health program for all of our first-year healthcare-related students called Putting Families First, and I am a course facilitator for that as well. So the expected outcomes of the lecture, this was on the flyer that was provided, but as a review, the hope is to cover today the prevalence of mental health and substance use disorders within the community at large, but then also specifically within the healthcare community. I think it's important for a lot of people to recognize this isn't an uncommon thing. It's actually quite common, and that is one of the first steps in, I believe, eliminating stigma, is that we're not alone. Right? And then we're going to discuss also the stigmatizing beliefs and behaviors that exist within the healthcare community itself, and then also touch on what are some of the resources that are available for healthcare professionals, specifically what we offer here at the UFHealth Florida Recovery Center, which is a nationally recognized substance abuse and dual diagnosis treatment center. So starting with looking at what is the prevalence? So first, we're going to look at the prevalence of substance use disorders in the general population. So SAMHSA every year does a national survey where they're looking at how many people are endorsing any kind of mental health conditions, substance use disorders, substance usage, so on and so forth. Whenever I present data like this to students I work with, I clarify you are always going to see it a couple years before the calendar year because it takes time to go through all the data they collect. So the most recent published data is from 2023. And as you can see, again, it's a common thing that exists in the United States among people aged 12 or older. So in 2023, there were 48.5 million people who indicated that in the past year, they had been diagnosed and met classification for some type of substance use disorder, with probably not a surprise, one of the most prominent ones is alcohol use disorder at 28.9 million. And then just looking at illicit drug use, this is also another common thing that people are endorsing. So for ages 12 or older, you have 70.5 million people who endorsed some kind of past year, with, again, probably not a surprise, the most prevalent being marijuana at 61.8 million. And then if you look specifically at mental illness and then serious mental illness, so the specification between those two things, obviously, any mental illness, this is any diagnosis that would fit under a DSM classification of a psychiatric condition like major depressive disorder, generalized anxiety disorder, OCD. Serious mental illness are the ones that tend to have more burden associated with them for the patient and for the community. So these would be things like a bipolar disorder, particularly bipolar 1, schizophrenia, so on and so forth. So again, if you look at the bars here, I don't know how large it is on all of your screens, but they break it down into 18 or older. So in general, what is the percent of individuals 18 and older in our nation who endorsed any mental illness and a serious mental illness? And then it breaks it down into age categories of 18 to 25, which is the green bar. The purple bar is ages 26 to 49. And then 50 or older is that light blue bar. And as you can see, in general, any mental illness is at 22.8. If you look at all ages, 18 and older, It's largest in the 18 to 25 age group at 33.8%. So over a third of those individuals have said in the past year they've had some kind of mental illness, and almost 30% in the 26 to 49. It does drop down in the 50 or older. And in the serious mental illness, you can see it also has lower numbers, but again, it's not 1%, 2%. In the 18 to 25, it's still at 10.3. So 1 out of 10 individuals have met a diagnosis of one of these more serious mental illnesses. And then one thing that I am also very passionate about is suicide prevention. Unfortunately, working at a place like I work, this has been part of some of the patients who have come through. I personally have lost patients who have worked with me to suicide, so I'm very passionate about it. This just shows the data from 2023 about adults ages 18 or older who had thoughts of suicide, made a plan, or attempted suicide in the past year. And there's a lot of colors and circles going on here, but basically the summary is down at the bottom, where 12.8 million adults had serious thoughts of suicide in 2023, 3.7 million made a plan, and then 1.5 million attempted suicide. And we do know, it still is across the board under 18 and even over 18 in the top 10 causes of death, and then one of the most preventable causes as well. And so here are the adolescents. So you had from ages 12 to 17, 3.2 million had serious thoughts of suicide. And the difference between that is they're actually thinking like, yeah, this is something I want to do. We sometimes distinguish between passive and active suicidal ideation. Passive would be more, I'm hopeless. If I don't wake up, that would be fine with me, but you're not actively thinking about this is something I want to do. Whereas active is more serious because there's more intent behind those thoughts. 1.5 million adolescents, again, 12 to 17, made a plan. And then we had 856,000 who attempted suicide in 2023. And then I always find this data very interesting because it really shows just how many people are not either getting the help that they need or don't even recognize per se that they need help with what they're struggling with. And this is specific to substance use treatment. So we already looked at some data to look at, well, how many people ages 12 and older in the United States met criteria for substance use disorder in 2023. This breaks it down into the adolescents, which are 12 to 17, and then 18 or older of people who sought treatment, thought they needed treatment, but didn't get it. And then ones that didn't even perceive that they needed it, despite, there would be a need to go get treatment. And every year that I've looked at this data, the blue overtakes any of the others, and you can see that on both of these graphs. So on the adolescents, only 0.5% of those that met criteria for substance use disorders sought treatment, whereas 2.8% of them thought they needed it, maybe wanted to get it, but for whatever reason didn't. But then an overwhelming 96.6% didn't even perceive the need for treatment despite meeting criteria for substance use disorder. And the same thing is happening among the adults. So again, we have 0.5% of them who ended up seeking treatment for substance use disorder, 4.8% who didn't seek treatment but thought, I probably should go get treatment, but then 94.7% who didn't perceive the need for substance use treatment. For so many, 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 many adults and adolescents who aren't getting treatment because there's not a perception of the need for it, or maybe there's just not enough psychoeducation. And I believe strongly stigma also plays a part into this because substance use in a lot of ways, like many of the mental health conditions, is seen as something that is more a willpower issue than a disease or something that would be in need of treatment. So how about within physicians? So that was the general community. They don't do a distinction between, healthcare professionals versus non-healthcare professionals. Well, most of the research that has looked at physician and their healthcare and mental health conditions, substance use disorders, have estimated that the lifetime prevalence for substance use disorders is somewhere between 8 to 15% of physicians nationwide. For mental health, we have rates that are similar and even sometimes slightly higher than the, we'll just say, non-healthcare professional population. So for depression, research has indicated rates as high as 29%. Anxiety, we have rates as high as 24% of physicians. And then even PTSD, wide range here. And a lot of this kind of depends on who are they doing the research with. But you get anywhere between 4% to 16% of physicians indicating symptoms consistent with a diagnosis of post-traumatic stress disorder. So now let's kind of move into, so we know it's prevalent. We know there's many people that struggle. So why are people not getting help, or why are they not even perceiving that they might need help? And again, as I would like to argue, and I truly believe, I believe stigma is part of the problem that is it's one of the barriers keeping people from treatment. NAMI has an entire website where it talks about being stigma free and what does this look like. But the highlights I wanted to focus on here are just looking at why are people not getting treatment, and hey, it's for something that's very prevalent and impairing for people who live daily with mental health. So here are some of the highlights. People experiencing mental health conditions often face rejection, bullying, and discrimination. This makes their journey to recovery longer and more difficult. This would include physicians. Mental health conditions are the leading cause of disability across the United States. Even though most people can be successfully treated, if they have a mental health condition, less than half of the adults in the U.S. who need these services and treatment get the help they need. And as we saw, the numbers are even way lower, right, for substance use disorders in particular. Often the average delay between someone's onset of symptoms, so when they first start experiencing impairing symptoms of a mental health condition, and then when they finally get intervention for it, so the treatment, is 8 to 10 years. Right? That is a long time to be dealing with impairing levels of anxiety, depression, obsessive compulsive disorder, whatever might be going on. And as we already talked about, suicide tends to be across the board every year in the top 10 numbers of leading causes of death. So for youth ages 15 to 24, it's the second leading cause. And for all Americans, it is still at number 10. So the 10th leading cause of death for all Americans. Stigma does exist in healthcare, right? I mean, I don't know about you all, but I always think to myself, okay, I'm in the helping professions, I'm in the healthcare community, I'm a clinical psychologist. Surely I wouldn't have stigma, right? But it exists. And we're going to talk a little bit about that later, about what we can each individually do to help with stigma and help to erase stigma. But I think the first thing we need to be aware of is it does exist in healthcare. So a study that was done by all the people that are listed there back in 2014 looked at physicians and their stigmatizing beliefs about people who seek mental health services, and thinking about if they themselves were to seek treatment for mental health services. And here are a couple of the highlights that in some ways are very disheartening, but I think highlights why is this an issue? Why is this a big issue within healthcare? Well, first, physicians who were less likely themselves to seek mental health services demonstrated in their practice more stigmatizing beliefs and behaviors with their patients. So there are many, and I know this because of the work I do and talking to people, that think, well, I think this way about myself, but that doesn't impact my treatment of others. This study suggests, yeah, it does. So if you yourself have some stigma about going and getting services that you might need or what that might look like, then it is going to play out in your practice. So for these physicians, they were less likely to refill their patients' prescriptions, particularly prescriptions that are things like SSRIs or any kind of anxiolytics, so things that are meant to treat mental health conditions. And they were less likely to refer to a specialist. So they were less likely to send the referral to a psychiatrist or to a psychologist or something like that. There was also a connection between stigmatizing beliefs of the physician and the greater perception of difficulties with medication adherence. So one of the things the physicians in this study indicated was, well, the reason they weren't refilling the prescriptions is because there was a perception that the patient wasn't adhering correctly to the medication. Well, they did an objective study of, is the patient being adherent or not, and found that even if there wasn't less adherence, so the patient was being adherent with their medication, the physician still perceived them as not being adherent. So it wasn't related to the reality of what the patient was doing. The physician themselves would assume incorrectly that the patient was not being correctly adherent. So, question, right? We know that physicians struggle with mental health. They are just as likely, if not sometimes more likely, to experience a mental health condition and or substance use disorders. So why not seek help? You know, what is keeping physicians? We already talked about the stigma, but let's just kind of talk about in general, you know, how many physicians are not getting the help? Well, research has shown that at least 40% of physicians are reluctant to seek treatment for mental health. So almost half, right, that are struggling with these things are saying, yeah, I can deal with it on my own. I'm not going to go and seek help. And again, we're going to unpack that a little more about why that is. Research has also shown that physicians working in states that probe about mental health on initial and or renewal licensure applications were 20% likelier than the ones that don't live in those states to be reluctant in seeking treatment. So you're already more reluctant just being a physician, but then if you work in a state where you know you're going to be asked about mental health conditions or treatment for those things, then you're even more likely to not seek the treatment that you probably and would benefit from getting. So in 2019, this physician did a study really starting to look at why are these physicians not seeking help and what is the impact of stigma and judgment and the licensure questions on physicians getting the help that would benefit them. This was a qualitative study, so she did a lot of interviews with physicians about their experiences with mental health and then their attempts to seek treatment or getting treatment. So here were a couple of the statements that really stood out to me when I read through the study. One of the physicians she interviewed said, after reading an article about one woman's journey through hell after being honest on those application questions, so again, the application of your renewal or initiation licensure questions, I sought care an hour away. I drove an hour in another direction to nervously fill prescriptions for antidepressants. I required several meds to stop thinking of suicide all day, every day. My suicidal thoughts were 100% work-related. So this was a physician who was suffering, really struggling, clearly very burned out right at work. But because of what they had heard or read about another physician who had responded honestly to application questions, they decided they couldn't get treatment in their own town. They needed to go an hour away, right? They needed to reduce a paper trail so that they wouldn't be caught, so to speak. And then another physician that she interviewed said, I've been in practice 20 years and have been on antidepressants and anxiolytics for all of that time. I drive 300 miles to seek care and always pay cash. I'm forced to lie on my state relicensing every year. There's no way in hell I would ever disclose this to the medical board. They are not our friends. So there's a perception, right, which may be based, unfortunately, sometimes in pieces of reality, that it's not safe to get help and it's not safe to be honest about getting help, at least from these physicians' perspectives. And I can tell you from my work that I've done for several years that I've also worked with a lot of healthcare professionals who think very similarly to these folks. So what are the state medical licensure boards and their applications doing? Well, a 2023 study back in September wanted to review, okay, what are states doing with these recommendations about the physician mental health? So back in 2018, the Federation of State Medical Boards provided 10 recommendations related to mental health for state medical license applications. So they had reviewed them. They had met with different mental health practitioners, done a lot of research, and they said there's these 10 things that we think we need to do across the board on our state medical licenses applications that's going to stop some of the stigma that's happening for physicians getting the help that they would need. Only 4 of them got adopted by some states. So 6 of them did not, 4 of them have, and the 4 that have been adopted by to some extent are only if impaired, only current, safe haven non-reporting, and supportive language. And so in 2023, and there was previous studies, so they do this every couple of years. They look at, okay, who's doing what right across the states. And there's 54 states and territories that are looked at. So obviously the 50 states, but then they also include Washington, D.C., Guam, the Northern Mariana Islands, and the U.S. Virgin Islands. And the applications get a score of 0 to 4. And looking at how it's scored, it depends on, does it ask questions? And you get a 0. So the lower the score, the worse it is, right? A 1 means you don't ask the questions or you do it in a respectful way. So only if impaired. 0, it asked questions about mental health conditions irrespective of impairment. So it just said, have you ever been depressed, basically. It didn't ask, does it impair your ability to practice medicine? But then you would get a 1 if you either didn't ask any questions about a disclosure of mental health, or you were specific and only asked questions about mental health with impairment. Only current, you got a 0 if the application asked about questions about mental health conditions that existed more than 2 years ago. 1 either asked no questions, again, that could require disclosure of mental health, or only asked about conditions within the previous 2 years. Safe haven. So people got a 0 if it didn't offer any kind of safe haven non-reporting. And then 1, you see a theme here. It's either if you asked no questions about mental health or you allowed for safe haven non-reporting. And then supportive language. If you offered no supportive or no moralizing language about mental health or self-care, you got a 0. And then 1 if you had any kind of supportive or normalizing language about mental health or self-care, which again, fits a lot into stigma, right? I definitely feel more stigmatized when people are not normalizing or being supportive of something. And I know many other people feel the same way. So 2023, how did our states do? Well, 3 of our states were inconsistent with all recommendations. So they got 0s across the board. 3 states out of the 54 were consistent with all 4 recommendations. So we kind of had the 2 sides of the spectrum. You had 3 that didn't have any of them, and 3 who said, yep, we checked the box on all 4. Well then, okay, so let's look at the 4 recommendations. So only if impaired, 39 of our states are doing that. 41 of our states are doing only current. Okay, that's pretty good. But the safe haven non-reporting, now we're down to less than half. That's 25 of them. And this is the one that, as a psychologist, really bothers me. Supportive language, only 8 of our states met criteria for that out of 54. So what I'm trying to say is there's still a lot of work, right, for us to do nationwide. In a 2022 survey of physicians, there was a question. So here you see a 2012 in the graphic here and an updated 2022, very similar results to this 2012 study. They just talked to physicians again about how are they doing, how's their mental health, what kinds of things have they struggled with. 1 in 10 had thought about or attempted suicide. 1 in 4, so a quarter of them, reported being depressed. The most cited reason of these physicians was being burnt out. There's a lot of overlap between those. 6 in 10, so 60%, reported inappropriate feelings of anger, tearfulness, and anxiety. And 80%, 8 in 10, agree that there is stigma surrounding mental health and seeking mental health care within the healthcare professions. In this same 2022 physician study, they looked at what are the specialties that tend to endorse being the most burned out. A lot of percentages here. As you can see, many of them are 40% or above of the physicians working in these fields. Probably not a big surprise. Emergency medicine and critical care are some of the top ones, but several of the others, we have almost half, if not, over a third, that are endorsing being burned out Lowest at 26% is public health and preventative medicine, but I don't want you to get lost at well, it's the lowest. It's still 26%, right? That's still 1 in 4 of these physicians who are struggling and burned out. And then why have you not sought help? So that was also part of this 2022 study. Almost half said I can deal with this without help from a professional. 43% didn't want to risk any kind of disclosure to the medical board, so there's still a lot of fear about them finding out. 32% didn't want it on their insurance record. That's very much related to job security, medical boards, so on and so forth. Quarter of them said they were concerned about their colleagues finding out. 22% were concerned that the medical profession would shun them. 11%, and this also makes me sad, they don't trust mental health professionals. So I guess there are things that we have done, or we have and again, I teach cognitive behavior therapy. So I always tell my patients, I like the word distortion because I believe that these thoughts we have are based in reality, but it's been distorted in some kind of way. So I will say, for my field, there have been people at times who have probably acted in a way that is not trustworthy. And other times where maybe there's just a belief about that, or I already know, I've had patients even tell me, I'm afraid you're judging me, right? So there's a fear of judgment and stigma even from the mental health care. And then they gave some other reasons, and that was at 21%. But again, the overwhelming reason is I can do this on my own, right? I'm struggling. I should be able to take care of this. So let's look specifically at a few of the fears that people have. So a couple of these studies, again, are the qualitative studies where they did interviews. And then I also wanted to give some of my personal experiences with patients that I've worked with. So where it says patient and then says a year, this was a patient that I worked with over that year who told me this when working in individual therapy with them here at the Florida Recovery Center. Well, from the CAR study in 2008, a physician said, sometimes we work exhausted or perhaps more ill than our patients. Covertly, we get the message. We are to rise above any human frailty. It isn't a conscious process. It is rather who we have become. So in other words, it's not like someone is telling me, hey, you're a physician, you need to be superhuman. I mean, maybe some people have been told that, but in general, it's almost like this is the understood theme within the healthcare professionals. We are to be above humanity and work through things on our own. Resilience isn't taught, but it is expected, and we come to expect it in ourselves and each other. Therefore, to admit a problem is to admit that we are somehow less than and not equal to our peers. We feel shame and we fear being judged and stigmatized, so we tend to suffer in silence and carry on in a profession that prides itself on stoicism and bravado. Another one from that 2019 study we already looked at, a couple quotes said, do you know what really hurts? The fact that anyone can look me up on the internet and read my dirty laundry. I'm publicly shamed by my medical board, punished for being ill. I will only know peace when I am gone. And then a patient I worked with in 2019 said, there was a group text that went around. It was about me, calling me all sorts of names and speculating about what had happened. These are my fellow nurses. How can I ever face them again? I think they forgot I was on the text string. So one of the very common fears that come up over and over and over, either in some of my CBT group homework assignments or working individually with me, from whether it's a nurse, a physician, a physical therapist, even other non-healthcare fields, teachers, lawyers, any of them, is my colleagues are going to judge me. They're going to shame me. And more often than not, we figure out probably not the case, but in this case, the patient saw firsthand, no, they're judging me and they're shaming me. They're calling me names. They're saying horrible things. She went on to say what some of those things were, oh, she's just a druggie. She should go live under a bridge, stuff like that. Really unhelpful. That nurse did not want to go back to her job. There's also a fear of perceived failure among a lot of the healthcare professionals I've worked with. And again, in some of the studies that have looked at physicians' experiences when they have struggled. So way back in 1994, Myers did a study that says, despite the biological substrate of clinical depression or the genetic underpinnings of alcoholism, so even back in the 90s, we knew, right? They're not just a matter of willpower or, hey, snap your fingers and feel better. There's actual biology behind it and genetics. Many physicians still believe these disorders are evidence of a lapse of will or moral failure, especially when they appear in other physicians. And I'll say this is probably still true in 2025, right? So 30 years later, I still think there are many who either think that's what their fellow physicians think, or maybe there are still some that think that. Right. And I will say we're looking at physicians, but even within the greater community, even of non-healthcare professionals, sorry, you're seeing a similar thing where there are people who think it's a lapse of will or moral failure. So I do have 3 quotes from some of my patients, one of them from 2020, one of them from 2021, and one of them from 2023. All of them are healthcare professionals. And actually all of them in this case are physicians. So one of them said in 2020, my brother-in-law hates me. He told his sister, my wife, so. He thinks I am not strong enough for her, that I failed her and my children. Yet he is an addictions physician. I just don't get it. Maybe it's just too personal for him. So this was unpacked a lot in our individual sessions together because for him, there was a big disconnect between this brother-in-law works in this field, right? Says that he has compassion for people who struggle with substance use disorders. He'll say it's a disease, and yet keeps telling my wife, his sister, she needs to leave me. I'm a failure. Look what I've done. She should take my children from me. And it was just a big disconnect for him, and understandably so, right? And then in 2021, one of my patients said, I got into Yale, and yet now here I am. Maybe I was never meant to be a doctor. So there was this struggle that he was having about, wow, you know, I've succeeded. Look at what I've done, but I have this disease. Thus, that disqualifies me from being a physician. And then in 2023, I had a patient who said to me, I might as well just give up on being a physician. I can't imagine anyone wanting to hire me. So there was a strong perception on their part that they were going to be stigmatized, thus unable to ever work again as a physician. Well, what really is addiction? Nearly half of all Americans don't think addiction is a disease. That's more recent. In a recent study conducted by the Addiction Policy Forum, they found that 30% of these adults in the US, they view addiction merely as a character flaw, right? They're just a drunk. They don't know how to deal with things. They just have something wrong with them, as opposed to they have a disease, right, that can be treated. And so we should support them in getting that treatment. In 2018, individuals didn't seek treatment for their substance use disorders because worries of negative impact on employment, that was at about 16% of these people, and worries of their community's view of them, about 15% as well. This wasn't with healthcare professionals, and I would say in my personal experience, now this isn't an empirical study by any means, this is completely clinical based, I would say at least over half, if not even over 75% of them are really struggling with being here for treatment because of the fear of the negative impact on their employment, their license, their ability to keep their job, their ability to get a job, and a lot of worry about the community's view of them because of their prominent role as a physician. All right, so with my students, I usually like to say, okay, well, we've talked about all this stuff, but let's be honest, we're humans. How does this apply to me, right? So I can sit there and I can think, okay, that's great. That problem's out there. But no, I think this is something that any of us here tonight, any of our colleagues, and really I would argue even any of our family members, friends, so on and so forth, this applies to them. Because let's be honest, we are all at risk for unintentionally buying into stereotypes, labels, and misinformation that will unfortunately stigmatize more than help. And any of us, again, that are here tonight, or that watch this on YouTube or that I would ever talk to about this, we're going to encounter individuals with mental health and or substance use disorders in our personal lives. So you might be sitting here tonight thinking about people you know within your families, within your social circles, within your religious organizations, within your friend groups, and you're like, yeah, I know they struggle with these things. And yeah, I know that they also are stigmatized or sometimes fear being stigmatized. And we're going to encounter this professionally. So no matter what field of medicine you are in, you are going to have patients come to you who have mental health and or substance use disorders, even if that's not your role, right? So I might be a cardiologist, but just because I'm only there to work on that doesn't mean the patient coming to me doesn't have other things going on with them. There is in general, and I didn't show it here in this lecture tonight, I didn't mention this at the beginning, but it seems like I'm being good on time. This is a lecture. I've adapted it from a lecture that I give every year to the University of Florida Medical Honors students. It's a 3-hour lecture that I give, so I had to cut it down. One of the slides that I present to them is the lack of access slides, where it shows how much need there is across the country for even primary care settings, let alone mental health clinics. So there's a great need, but the supply is very, very low. So because there's a lack of access in general nationwide to mental health providers, there is a need for integrated care within primary health care settings and possibly even others. So I've had multiple patients meet with me either here at the Florida Recovery Center. I also carry an outpatient caseload of Gainesville community members, lots of college students who come to the University of Florida, basically anyone who needs a psychologist who takes insurance is how I sometimes say it to people. And a lot of them are trying so hard to get a psychiatrist, right? Because they recognize, hey, this would be really helpful if I have both the psychological treatment as well as psychiatric treatment. And it's really hard to get in, right? They either are on a wait list of like 6 to 8 months out, or their insurance isn't taken by anybody locally. And so there's even discussions I have with folks of who are some of the other healthcare providers that you could at least initially maybe connect with to get this help rather than waiting 6 to 8 months out. And often we talk about people like primary care physicians, or we even talk about people like OBGYNs for women and things like that. So again, even if you're not in a mental health specialty, there's still a need for you to know, okay, what are mental health conditions? What actually helps? How can I help facilitate getting these people the treatment that they would need? And then also, I don't know any of your all's backgrounds. I don't have crystal balls to show me your futures, but some of you on this call and definitely some of you on YouTube may also individually, personally benefit at some point in your life seeking services from a mental health care provider. And so I think thinking about how am I allowing both the perception of stigma as well as maybe some legitimate stigma I'm getting, how am I allowing that to affect my decisions to get the help that I need for something that I'm struggling with? So what do I do? All right, so how does it apply to me? And what do I do? Well, first, get honest about your own stigmatizing beliefs. So think really deeply and think, okay, do I honestly have any kind of stigmatized beliefs about individuals with mental health conditions and or substance use disorders? What are those, and how can I start to break out of those stigmatizing beliefs? We can also, each of us in here, become more aware of our own mental health and risk factors. And if we see that, yeah, actually I am struggling, be willing to seek help. Across the board, as I said, this is something really near and dear to my heart. So I talk about this probably a little more than what people like. But I always tell people, I think we have all these programs, we have these national initiatives to break stigma in the schools and hospitals, wherever it is. But really, it's going to be a grassroots movement. It's going to be us one by one saying, you know what, I'm going to stand up to this. I'm going to stop stigmatizing. I'm going to practice in a way that doesn't stigmatize or discriminate or, invalidate. And I think the more and more of us that get on board with that, I think the more and more we're actually going to start reducing and eliminating stigma. We also individually do not want to feed stigma with misinformation, assumptions, and or labels that are unhelpful. And sometimes we don't know if they are or not. I mean, I think sometimes we say things and we don't mean them as unhelpful or invalidating, but we don't always recognize that what we're saying may do more harm than good. So it's just getting educator really starting to pay attention to checking in with the people that we're working with or things like that. We want to also, no matter what specialty you're in, provide patient-centered care that accounts for all aspects of an individual. So all aspects includes emotional and mental well-being and health. So we want to listen, we want to empathize, we want to seek to understand, and always remain ethical, right? So in other words, don't decide, hey, I'm going to start acting as a psychologist, even though I'm a proctologist, or something like that. I'm not saying that you can't do a little bit of reflective listening, but that's not your role, right? That's when you would want to know, as the last point says, what are the mental health services and resources in my area so that I can help point my patient in the correct direction to get the help that they would need. So back to the NAMI website of Stigma Free. They have some good recommendations of how to help reduce stigma. Again, they also argue that everyone can play a role. Everyone means all of us as well. They give a lot of the same things I just talked about. So the respectful language to talk about mental health conditions. You want to challenge misconceptions when you see or hear them. You want to see the person and not the condition. So, even within substance use, we're getting away from terms like, oh, he or she is an alcoholic or they're an addict. Instead we're saying they have an alcohol use disorder or they have a substance use disorder. And then offer support if you think someone is having trouble. So if you start to notice, my colleague just seems a little bit off, instead of judging, instead of being like, man, they need to da-da-da-da-da, offer to support, offer to encourage. Now, you can't make them get treatment, but you definitely can do things that will facilitate them feeling supported and like it's okay and safe to get treatment, as opposed to, oh, this is a good indication that this is not a good idea for me. And you want to avoid labels. There's some of them there. I sometimes tell my patients, I have the doctor's stars, no words, crazy is on there, stupid is on there, irrational is on there. And many of these others would also be on my no words list as well. And this is true even in the medical conditions, instead of labeling the person as the condition, we want to say they have or they're living with the condition more than general, and especially when we're around patients. So maybe we're not speaking directly to them, but I'm in the hospital cafeteria or I'm on an elevator and I'm talking to one of my colleagues. Oh my gosh, I saw this person today. They're bipolar and da-da-da-da-da. I mean, you don't know what kind of message that's giving to the people that are around you. So probably don't even talk about that in the elevator either. So want to be HIPAA compliant as well. So now I want to shift our focus to what's near and dear to my heart, where I work, and what we're doing to help with both destigmatizing substance use treatment disorders, but then also what we do to help healthcare professionals across the nation who present to us with substance use disorders. So I do work at the University of Florida. We're now UFHealth. We're under the umbrella. So UF College of Medicine is linked with the UFHealth Hospital. And so it's UFHealth Florida Recovery Center. We're a nationally recognized dual diagnosis substance use treatment facility. We do have both non-professional and professional tracks here at the Florida Recovery Center. So basically anybody 18 and older can come to us, no matter what their background is. And we were the first facility to receive accreditation from the Federation of State Physician Health Programs, FSPHP, which was something we were very proud of, have worked really hard. I don't know if you have ever heard of or have talked or have seen Dr. Scott Teitelbaum, but he's a very passionate man and loves what he does. And he's really gone out there and to bat to really give quality treatment for these people and share to the states what we're doing for physicians. We do use a 12-step model, so we are based on the 12 steps of Alcoholics Anonymous, Narcotics Anonymous, all those. But we also provide several additional groups. And I'm going to talk specifically about the group that I run, Cognitive Behavior Therapy, both as a means that you can see, well, this is part of the treatment component here, but also this is part of how I personally try to destigmatize things with my patients that I work with. So we offer that because I'm here, I teach it. But we also offer groups in dialectical behavior therapy, DBT. We run groups on the Enneagram. And we also have recreational therapy. We have lots of others. I just didn't want to, have a slide that have everything, but we try to cover all aspects of an individual. And the length of stay, particularly for our healthcare professionals and really ideally for anybody, is approximately 90 days. And the reason for that, there's two reasons. One reason is the research has consistently shown that if patients are able to get around 90 days of treatment, they're much more likely to be successful 6 months out or even a year later to be sober than if they don't. So 28-day programs don't have near the backing for sobriety that 90-day programs do. But also there's a certain track that people do. There's certain assignments they do. And it takes approximately 90 days to successfully complete all those. So to actually get all the components of our program, someone would be here about 3 months. This map that shows here, this is a map of where all of our healthcare professional patients have come from. As you can see, all the colored in states, these are the states that we have had people come to us. However, I noticed, because I was like, wait a minute, I know I've even worked with someone, for instance, from Minnesota, so it's not up to date. There are other ones that need to be filled in at this point. So for instance, Maryland is one of them. We have had physicians from Maryland. We've also had some physicians from Wyoming, Minnesota, Washington, D.C., and even currently on our campus, we have 2 physicians from Arkansas. So I couldn't validate some of these others. I was going through old census and just my memory, but basically we've had people from across the nation who have come to us to get treatment. So CBT is near and dear to my heart, cognitive behavior therapy. I don't want to just assume that everybody knows what that is. So basically what it is a treatment that's based upon the principle, I call it the triangle, where our thoughts, behaviors, and feelings are interconnected. And so that's something that I really focus on with the work that I do, either in group format or individually with patients here at the FRC. Is focusing on how do their thoughts and behaviors and emotions go together, and then how can we make healthy change at the thought level and the behavior level, so that also we make healthy change at the emotion level. I do this, as I already mentioned, in an individual psychotherapy format. That ranges at any point between 12 to 15 of our partial hospitalization program patients, not physician health program, but there's just too many PHPs, I'm going to be honest. But for here, what that means is partial hospitalization. Most of them do live here on campus, but it doesn't meet full criteria of a residential program. We don't have like locked doors or, any of that. So it is a partial hospitalization program. Currently, I have 28 outpatients. 17 of my 28 are former FRC patients, so they have continued with me in an outpatient setting. In order to do this, they have to at least live in the state of Florida, because I'm only licensed in the state of Florida, and so they continue with me. If they live out of town, they do telehealth. If they're here, they typically come in. And then I do have a former FRC intensive outpatient patient who also meets with me. So 18 out of 28 of my current ones are at least affiliated with the Florida Recovery Center, so have at least one diagnosis of a substance use disorder. And then I have the CBT group series. My CBT group series is a series of 5 sessions. So they meet with me for 5 weeks. I primarily focus on thoughts. My first group, I like data, so I have this data. I'm kind of nerdy that way, but my first group was on August 23rd, 2013. So in other words, I've been doing this for a long time, right? This August, it will be 12 years that I've been running CBT groups here at the FRC. In total thus far, I've had 2,526 patients referred, and this has been across 268 separate groups. So this has been something that's been integrated for a while. A lot of people come, and this is pretty good because I do cap my groups to 10 to 11 patients at a time, just because part of the series includes homework. And when I give them homework in the following week, I want them to review their homework with the group. And so if it gets much bigger than that, there isn't a lot of time to do much of anything else except review homework. So I found that number works pretty well. All right, so as I mentioned, I want to unpack this just for you to get a taste of, well, what does this look like at a substance use treatment facility? But also, I want to talk about how I use the things that I cover to help address stigma and to work on some of these tips that I had shared with you all. So in session one, basically I introduce the group, I introduce who I am, I have them introduce who they are, I tell them, okay, this is what the group is, and then they get the handout that you see down here, the 3 parts of our personality, so our thoughts, our emotions, our behaviors. As I like to emphasize over and over to them, these parts directly impact the other 2 parts of the triangle, so each part does. So we also talk about something called the negative cycle, the negative trap, or the self-fulfilling prophecy. So basically, I think a certain way, which then impacts my emotional reactions and my behavioral reactions, which unfortunately sometimes end up self-fulfilling the distorted assumptions that I had, not because, ooh, I'm so smart, but because of the interconnection between our thoughts, feelings, and behaviors. We then talk about core beliefs. So because I talk about thoughts, I show them a flow chart of, we all have these core beliefs that impact our assumptions, that impact our automatic thoughts. And then I give them a list of cognitive distortions. And then for homework, they have a thought record. And basically what they do over the week is they think about either a time that happens that week or previously in the past where they themselves engaged in some distortions. Now, one thing that I emphasize a lot with the people that I work with, and I particularly emphasize in group number 1, is I emphasize this is very human. I say that a lot because the patients that come here often think they are somehow broken or different from any other human, Now they still, because in AA and NA, they still use the words alcoholic and addict. So the patients talk about themselves that way. I don't know at what point that's going to change in those recovery communities, but that's where we're at right now. So they'll say something like, I'm an alcoholic. My friends that aren't, they wouldn't think this way. Like there is a belief that if I somehow didn't have this, then I wouldn't be thinking this way. I wouldn't be feeling this way. I wouldn't be acting this way. And I try to emphasize in the first group, this is actually really human. Like we as humans have distorted thoughts. We have unhealthy behaviors and we have emotions that aren't always the most helpful as well. And another thing that I really emphasize in the first session, and I'm going to get on my little soapbox now for all of you as well, and I do this frequently with the patients that I work with, is we want to eliminate the term irrational thoughts when we're talking about things that I think more accurately and more helpfully are cognitive distortions. So when CBT started, and I'm very thankful for the founders of CBT, so I don't want to speak bad at all, but many of them did refer to these things as irrational thoughts. For instance, they said, oh, the reason why people are depressed is because they have these irrational thoughts about themselves and their future and the world around them, hence why they're depressed. So in order for them to get better and not so depressed, we have to make them more rational, right? Well, from the outside looking in, it appears to be irrational because you look at it and you say, how can you sit there and say you're a failure and yet you're the CEO, you have a Ph.D. and an MD, you have a wife, you have a house, you have pets, but what the problem is that when you really talk to the person, and I have, because I'm a psychologist, I actually listen, to my folks. That's a good, I always say, if I don't, I need to find a new profession. That's just rude of me. But when you really talk to somebody and get to see why are they thinking that way, it's actually pretty rational why they're thinking that way. which is why I want to get away from the word irrational, which basically people equate with things like crazy and stupid, right? And really go to distorted, because it's always based in reality. There are aspects of reality in it, but it's been distorted in some kind of way. So common cognitive distortions would be things like catastrophizing, all or nothing thinking, mind reading, if only thinking. There's many of them, but these are examples of distortions. All right. So then in session 2, we do a homework review, and then we start what becomes a 3-week session, 3 weeks of discussing cognitive strategies to challenge and reframe our distorted thoughts. So these are some of the ones that we talk about in the first week. Cognitive techniques of questioning what you really mean, questioning the evidence, and reattribution. The little asterisk next to questioning the evidence is because this is the one that is used as homework for the patients. And one of the things that I emphasize before I start talking about them, that again, my hope is to really get everyone to think, okay, I'm not this crazy person, right? Is balanced thinking is not about just rationalizing your thoughts. So again, I present the argument that you're not being irrational and crazy when you're thinking this way. It's actually really rational. So if you try to use logic to get yourself not distorted, it's probably not going to work very well, because the problem is not with how do you rationalize the information coming in, it's what information are you taking into consideration. And that's where selective abstraction and disqualifying the positives come in. These are two of the distortions. Selective abstraction says I'm hyper-focusing on certain details, and then I discount or disqualify anything that is not consistent with those details or with the conclusions I've already jumped to. The other strategy is balanced thinking is also not about seeing everything positively. One of the things I'm really trying to myself do for grassroots movement is to eliminate the idea that healthy always equals positive, at least when it comes to our thoughts, feelings, and even to some extent our behaviors. Because me thinking positively and feeling positively at all times is not always healthy, because the world is not always positive. So one thing I emphasize in session 2 and really beyond that is you're not just trying to sugarcoat everything or just see the good in anything. You want to face reality, right? Which is really that final point that's in bold there. Balanced thinking is really about looking for information that you are otherwise overlooking. So it's broadening your perspective to look at all the facts and then come up with what's a more realistic, balanced thought. Okay, so in session 3, we review the homework. They then get 6 more discussions. So there's a total of 15 of these techniques, but the ones they do for homework are examining options and alternatives, decatastrophizing, and examining expected consequences. I also talk about listing advantages and disadvantages, turning adversity to advantage, which I'm going to talk about in a minute, and labeling biases and distortions. So I say I'm going to talk about turning adversity to advantage in a minute, because I think this is one of those just not very helpful description. Now, I'm going to be honest. I didn't come up with all of this on my own. And I tell my patients that. I don't copyright things and, say, oh, it's mine. I came up with it. I got all this from all these different resources I've accumulated over my years of being a psychologist, the training that I did, my internship that I did, all these things, or things like this. And where I got the technique for that one calls it turning adversity to advantage. But I don't like the term for it. And I actually think in some ways that can be very stigmatizing to somebody, because there are some things that happen in life that it's really hard to see how could there be any good that comes out of this, especially when you're in the midst of it. Like when you unexpectedly lose your partner or your parent or your child. The last thing you need is somebody saying, oh, look for the good. Things are going to work out, right? And so what I call this strategy is the put the telescope down in adversity. So this is one of the ways I try to counter, right, what I believe can be a stigmatizing belief. And what I mean by put the telescope down in adversity is when we are human, and one of the things we as humans do is we tend to hyper focus on the adversity when we're going through it. So the perception is this is all there is in my life. Hence why we have some of the emotional and behavioral reactions that we do when we're facing challenges and adversity and difficulties. And then what we unfortunately do as humans, and you'll notice this is the language I use in my groups. I keep saying as humans. I don't say you all as addicts, right? I say as humans. We are human. I do this as well. That's something I will often say, me included, right? And what we tend to do, which is not helpful, is we tend to shift our telescopes over here and say, oh, but look at all the good in my life. Yeah, that's going on. But you know what? Let's not think about that. I've got a house. I've got these kids. I've got, my health, da, 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 da. And we're trying to sugarcoat and sugarcoat and sugarcoat. But you know what? We're not stupid, right? We're not stupid. So we go back to the adversity. And now I'm hyper focusing on that. Put the telescope down means I still acknowledge the adversity, but within the greater context of the reality of what I do have and even the hope of what I have in the future. So that's one of the ways in session 3 I try to work on eliminating stigma with my patients. And then in session 4, we do another homework review. You'll notice a theme here. And then the final techniques that we talk about for the cognitive strategies to challenge and reframe our thoughts are scaling, replacement imagery, cognitive rehearsal, self-instruction or coaching, thought stopping, and self-compassion. So the self-compassion is kind of the final big focus in my 4th group of where I really try to destigmatize anything that somebody may be experiencing. I really talk about, we really need to treat ourselves with the same compassion and respect that we would anybody else. And I do acknowledge in the group, maybe some of you sitting here, because I don't know all of your backgrounds or how you think or, anything like that. There may be some of you where you're like, yeah, I got that. I'm not so compassionate towards others, right? So I usually say, if that's you, you don't have to tell me, but take everything I'm saying and apply it to other people as well. Or even if you're someone that struggles with both ends of that, you struggle with compassion towards yourself and others. Really, you got to see yourself and others all as human. And that's when I tell them, for me, that's really powerful because I truly believe every human being in and of ourselves are denoted with value, dignity, and worth. So you have dignity because you're a human, and that person has dignity because they're a human. So start treating yourself and others as such, right? Don't put such high expectations on yourself. We don't want to stigmatize things, so on and so forth. And then the homework is a self-questioning technique. This is meant for behavior. So basically, it's a technique where you look at an avoided healthy activity and you examine, well, what are the barriers that are keeping me from it? And then how can I build my motivation to do it? And then finally, in session 5, I just kind of cover a variety of things. So we do the homework review, and then we talk about the problems of judgments and converting judgments to non-judgments, which is, again, one of the main ways I try to address stigma with my patients. So we talk about, here's how judgments come about. This is why it's unhelpful. But then how can we then reframe those judgments into balanced, realistic thoughts? So really getting to the heart of, instead of jumping to these judgmental conclusions, what's actually going on, right? What are the facts of a situation and how do you feel as it relates to the facts? And then we talk about some other things like patterns of mood, assessing one's activity level. I give them a graph of anxiety over time and then talk about how exposure with response prevention is the gold standard treatment for a lot of these anxiety-related disorders like obsessive compulsive disorder, social phobia / social anxiety disorder, any of the phobias, as well as many of the trauma-related. And then I give them a list of resources. But then that's it of my CBT group series. And that's it of my lecture with still some time to spare. So we made it, and it looks like Zoom made it. So because right now I don't see you all. Let me stop my share for right now. All right. So we can get into some questions in our final remaining time.
Great. Well, thank you so much, Dr. Starr. You have given us definitely a lot of information, but also a lot to think about Thanks very much about your insights into, what you do and how, there are opportunities for us to change our thinking. I think that's so important. As I said, please put comments or questions into the chat. If you just really need to ask the question, please raise your hand. We'll unmute you and definitely want to hear from you. We do have one question, though. How do you square the 12-step model of identifying as an alcoholic or addict and the destigmatizing approach of saying a patient with AUD or SUD? Oh, you're on mute.
I forgot I did that. That's hard. That's something I've actually thought about a lot, especially anytime I present this lecture to our medical honors students. I obviously, as an individual, I have no power to go into AA or NA or any of the A's and change the way that all of them are talking about something. But it is something more so on the individual level that I do. So if they come to me and they talk about, I'm an alcoholic, I say, well, it's not you as a person, or that's not your identity. It's really like you're struggling with alcohol. And so for the ones that I'm able to talk to, I often say, this is the language they use, but in your own mind, you need to stop the overgeneralization to identifying yourself as that thing. Right? And so my hope is that I'm not going to say it's going to be me, but I'm hoping many people have these conversations and then they themselves bring it into the AA and the NA halls and rooms. And that over time, you start to see more and more groups who say, hey, let's really get away from this. I don't know exactly how they would do it. It's just, to be honest, I think part of it is just more succinct to say, hi, I'm Jill, I'm an alcoholic, instead of, hi, I'm Jill, I have an alcohol use disorder, right? We don't like a lot of words. We like to just kind of keep things short. So I don't know how that would play out. But my hope is that I'm not the only person who's having some of these discussions with people, and that as more and more people get educated, or, as more and more, I don't want to say as more and more healthcare professionals get in these communities, because I don't want to say, oh, there's something, we're so much smarter than the community. But many of us have access to the education about these things where some of the others don't. And so I think the more and more this gets into the rooms, there might be a shift. I don't know. I don't have the crystal ball to show me. And that's definitely something that I personally am like, I don't know how to reconcile about that.
Thank you. Another question. What about this subject is getting included in the educational curriculum in allied medical associated medical career professions? So not just physicians, but others too.
Yes. So I can only answer that as it relates to the University of Florida, because I don't know about other places. I'm going to be honest. Sure. So I don't want to misspeak outside of what I actually know. So again, I even orient CBT. I'm like, what are the facts? So this is coming from the Putting Families First model that I mentioned that I'm an instructor with. So basically across the board at the University of Florida, all first year healthcare related positions. So we have veterinary students, we have, vet med, physical therapy, PA, dentistry. We even have occupational therapy, clinical psychology, obviously medicine, so nursing. It's basically all of them. Part of the curriculum addresses stigma and healthcare equity and things like that. So I know at least in that course, the University of Florida tries to touch all of the professions that are going to be working together in a healthcare format to talk about stigma that might be addressed. And then I, as a facilitator, bring in some of the same stuff that I talked about that I do with my personal patients. Now, I only work with, a group of maybe 16 to 20 students, and this has hundreds of students, but that is part of our curriculum. And then we were also one of the first programs nationwide at the University of Florida to include a lot of substance use treatment kind of education with our College of Medicine, including when they are on the psychiatry clerkship, they do a rotation here at the Florida Recovery Center so they can really learn who these people are that present. And so many of them walk away with, wow, like this really eliminates any of the stereotypes that I have. And then we also give lectures to many of our like second year medical students, stuff like that. I know many of us try to get our information across to medical boards and things like that. Again, I can't speak. I've never been part of any of that personally. I would love to get involved with some of that personally. But I know we've got several people here who have a passion for destigmatizing and making sure treatment is accessible and seen as necessary, and that physicians do recover, thus have the right to get into their fields and work and so on and so forth.
And that really is also just I think probably many folks on this call know about physician health programs and may know that there's a federation of state physician health programs, but that's a big message that we try and get across within our programs, to others with other states, with our medical boards. But as I think you're saying, Jill, it's kind of ingrained somehow in the culture that getting help is wrong, and getting it uningrained, whatever that means, is a process that clearly you're doing a lot of work on, and we all need to be doing a lot of work. My piece of that. Other questions? And again, if folks just want to, unmute yourselves or raise your hand to ask a question, that would be great too. Okay, anything else? Well, I have to again say thank you so much for being here, for presenting all of this great information. Just a reminder, this lecture has been recorded and it will be on our YouTube channel. Also, just a note that I'll be sending tomorrow out a link for the CME questionnaire. Please, however, don't expect to get your certificate until probably sometime next week. And I do want to also say that the Federation of State Physician Health Programs conference is next week in Seattle. So all of MPHP clinical staff, our clinical managers will all be there. So we're very eager about that. I'm also going to put a plug in because one of our clinical managers, Holly Wade, will be co-presenting on a trauma-informed model of physician health, which I think really goes hand in hand with what you're talking about today. So I'm really excited to see that. So great presentation. And another comment, we need to treat our medical colleagues with the same grace we give our patients. Absolutely.
Yes. And so family members. Like that one physician experienced. Yeah.
Yes, absolutely. So a number of thank yous. Great presentation. Thank you so much. Very informative. Any parting comments for us, Jill? Anything before we?
I'm just so happy Zoom survived for today. I was a little bit nervous, but I appreciate you all taking your time out of your evenings. You probably saw the little one that was in the back here. That's my youngest. My oldest is 17 and working at Wendy's tonight. She's trying to save money for college. And so she was not home to watch the youngest, and I'm a single mommy right now. So I appreciate you bearing with the 9-year-old kind of making little movements across here. But this is something, in my personal life, I try to do this with my children too, because it's interesting. My oldest is very good about this, and she herself in the local high school tries to destigmatize things. I'm like, please go into this field. Please do something, she wants to be a criminal investigator, but we'll see. The middle he's a middle school boy. So we're still working on that in progress. and the youngest is, she's on elementary, but working on that as well. So I think we can do it in our homes, in our professional lives. As I said, I really believe it's going to be a grass movements thing. And yeah, I can put, someone did ask, I'm going to put my email in the just chat for everybody. So if anybody just needed to reach out to me with any questions, or, as I said, we have started relationships with Maryland for our program. So if you know of anyone that would benefit, I'm happy to hook you in or talk through what it might look like, or, things like that. Obviously, all HIPAA compliant. But here is the email if anybody needed to reach out to me. So
Great. Thank you very much. And just so everybody on this call knows, we have MPHP has referred folks to Florida's program. We're very happy. We're very thankful for all the work that you do. It's very important, and as you said, it's all of us coming together, working on this issue, looking at it in a different way, and supporting each other with grace, as it was just mentioned in the chat. So thank you. Thanks to everybody for being here this evening. Very, very much appreciate your coming. You're listening to Dr. Starr. You're participating in the Lemons to Lemonade lecture series. Please, like I said, look for the questionnaire tomorrow, but don't look for the certificates until next week. And everybody have a great, great evening. Thank you so much.
thank you.
All right. Good night.